Just a reminder, no PHI may be shown during this call. I took out all of the PHI during the slides. And yeah, Dr. Hitt, you can go ahead whenever you're ready.
Thank you. Thank you so much. So I'm one of the endocrine attendings at Johns Hopkins. I also have one of my fellows joining, Dr. Mastora Polo. So in case she has anything to add or any additional questions, she may be chiming in later. This was a case I presented to my division, and we had a couple questions about it as a division, and so I wanted to bring it to this format. Diagnosed with diabetes, but just to clarify, she has not yet had uh, a full diagnosis of diabetes. She's had elevated A1Cs. So that's, sorry, what I meant was elevated A1Cs noted since 12 years old. I'm sorry, noted 2 years ago. I apologize. Now she's 12 years old when she was first referred to me. When she was first referred to me, she had A1Cs that were about 5.6, then later found to be normal, and I did not follow back up with her. She returned to me with an A1C of about 6.3 this spring. When she came to me the first time, and still, she has a very low normal BMI. So she's been at about the fourth percentile. She has always had trouble gaining weight, so she's never been overweight. And I sent her for monogenic diabetes testing through GeneDx, which did show this variant listed here in HNF1 alpha variant unknown significance that was heterozygous and looks like a deletion from 1380 to 1406. I did send diabetes antibodies multiple times because I sent it 2 years ago and I repeated. I sent four antibody testing and all were negative. Mother reportedly had type 1 diabetes, which is what prompted that evaluation. And then now I've done a couple oral glucose tolerance tests that I have on the next slide. I'll show you, and the C-peptide results at the 2 hour were elevated. So I wanted to ask about that. Her prior medical history, she was born extremely premature. I believe it was 25 weeks. So she is currently, and she has autism, developmental delay, and ADHD. So her medication regimen is dexamethylphenidate and guanfacine for her autism and ADHD. And then she has previously been on a lot of medications for support with weight gain and reflux. Is currently on cyproheptadine, and she was on chlorothiazide for chronic lung disease when she was younger. Her most recent A1C, she has had some improvement to 5.9 recently. So here's where I mentioned some of that additional medical history, prematurity, ADHD, chronic lung disease. She was born small for gestational age. She does have some recent seizures that are being evaluated that do not appear to be related to abnormal sugars. She had optic atrophy and she has severe developmental delay. The family history was interesting. Mom has what she thought was type 1 diabetes that was diagnosed at age 21 in Puerto Rico. She says that she's never had antibodies checked, but she does remember her A1C was 14 at diagnosis, and she's currently treated with an insulin pump. Her maternal aunt also has what they believe to be type 1 diabetes, diagnosed at 15. And the only other family member with diabetes that she reported was a maternal great grandfather who she said was diagnosed in adulthood and needed insulin from the beginning. So when I first evaluated her this second time around, I got the diabetes antibodies, which were negative, and I started her on a CGM. Mom preferred that to glucometer checks due to developmental delay, and I noted some 200 to 300 postprandial glucoses. So I sent her for an oral glucose tolerance test, which was found to have a 2 hour glucose of 216. So this is a little bit confusing, but I just to walk you through it. On the very leftmost column was the first test this spring. So her fasting glucose is the 85. One fasting glucose was the 85, another was the 68. So one was, I'm not sure why two fasting glucoses were sent, but that's the two that were resulted. And then the 2 hour glucose was 216. I ordered a C-peptide and insulin primarily to get what I thought would be a fasting C-peptide and insulin, but it seems as though the lab could not draw enough blood during the fasting check, so it may have been done postprandial, but they were quite elevated and surprising to me. Again, this girl is underweight. She does have some hyperpigmentation on her neck, around her umbilicus that I could maybe say looks a little like acanthosis nigricans, but not what I would typically think of as a girl who looks insulin resistant. I repeated her fasting glucose, insulin, and C-peptide. So that is the next column, the second column. Those are all fasting. So she had normal fasting, insulin, C-peptide, and glucose. And then I did a repeat OGTT in our clinic, just in case it would be done better, more accurately. And so the fasting glucose for that was the third column. That's the fasting insulin and C-peptide. So it was 82. And then the 2 hour, this second time around was 131. But at insulin C-peptide were still elevated at the 2 hour mark. So this is really the thing that was curious to me and my division because we, in the meantime, also MODI testing was cooking. And when it resulted as a HNF1 alpha mutation, we were curious if this kind of fits the picture of the HNF1 alpha monogenic diabetes, given that she has elevated insulin and C-peptide, and if there was any further workup I should be doing. As you know, the sulfonylurea would be a typical therapy for the HNF1 alpha MODI. We were kind of wondering, if that would help someone who already has, these elevated postprandial insulins. We were just a little bit confused by the picture, and we're curious as to the thoughts you may have here.
Well, this is awesome, and thank you so much. I think you are right that this is confusing. And I was reviewing, what we've said about this together, and I can tell you a couple of things straight away. I mean, one is that this ought to be a condition of insulin insufficiency, right? So you're absolutely right. And so an 8.4 on a C-peptide is strangely high. And we also have lots of other features here, which arguably could help explain some insulin resistance. So it's possible that, we have two things going on. One is that she's actually insulin resistant, and her sugars should be even higher than they are with this syndrome. And that the limitation causing diabetes is that there is some uh, loss of insulin secretion, but it's not clear. So what we found out about this, and what I think we've been in communication with you, is that this particular variant, and I don't know if Ava, I sent you the map that Bala had sent us back on August 6th. I don't know if you can put that slide up, but it shows where the deletion is. So the deletions you said from 1380 to 1406 wipes out glutamine at 460 and continues to the leucine at 468. So that's a 9 amino acid deletion in a region that's been reported previously. So it was classified as a variant of uncertain significance in that previous report. And there's a couple of things that are interesting. One is that the frequency is relatively high. So while there's 3 zeros of the filtering allele frequency at 0.009615 in an admixed population, that's higher than the pathogenic frequency that we usually use as a cutoff, which has like 5 zeros in front of the first significant digit, so 0.000003. And that difference suggests that this could be something more common that, I mean, obviously not all that common, but common enough that maybe it doesn't really do anything. So in which case, then, what is the region of activity? And that's why I wasn't sure if Ava could show us a map of where the 466 to 488 amino acids lie. But on the one hand, it's important for transactivation. So if that means this is a part of the molecule that doesn't sit down on the DNA. And most of the mutations in the transcription factors, 1 alpha and 4 alpha, are actually in the DNA binding domain, not in the transactivation domain, although there are some. So, all right, so this was a partial map of this transcription factor, which has a lot of extraneous information for sure. But the region at 460, you can see in the middle there, and what we said, if this thing is correct, that 460 ought to start with a glutamine, which is here. So this Q, and you can see it's well conserved from human, mouse, um, and even Xenopus and zebrafish have a queue here. Then there's a little bit less conservation in the next few, and then it goes all the way to leucine at 468, which is this guy in the human sequence, which is still reasonably well conserved. Then Xenopus has a small insertion in here, and then it takes off again. So it's in this region, the transactivation domain. It's not known to be in a site specific for specific kinases, but you see on the map up above, so 460 to 468 does take out part of this region on the right-hand side. I don't know if you can see my cursor, but it's two from the right-hand side.
I can't see the cursor, but I'm following.
See if yeah, so it's right up here. So in the blue line, the droplet promoter region. So these are all interesting regions that are still not zero. So we can turn that off, I think now. So having said that, what do we make of this? So if you had found that her C-peptide was low, you probably wouldn't have even called us in the first place. And you would have just said, this is, a transcription factor Modi, and we're done. But the part that remains is the family history, at least to my way of thinking. What else? I mean, one alpha is not as syndromic as some of the others. So, if it was one of the other ones, we could say, well, what's going on with the liver? What's going on with the kidney? And we don't have to do that here, but she certainly has a lot of other stuff. I mean, and we don't have an explanation necessarily for all the other stuff, right? I mean, there's no other chrom.
Prematurity, but I did send a liver ultrasound and it was normal after getting this mutation result.
And have you done even a chromosomal display? So just a very large scale. Because sometimes there's a deletion somewhere else. I think one of the things that we have been realizing, and we just, in fact, the second case we're going to talk about today is when there's two different causes of diabetes in the same family. Here, it's possible there's like another chromosome abnormality, that she has a translocation or deletion somewhere else. And this is like not helpful, but it's not the thing itself either. So I think, sorry, it was, yeah. So I think doing something, more broadly, uh, which, I feel weird telling you, I'm not a card-carrying pediatrician, but I think that is still possible now that the beauty of these interactions is that we think about them differently with like you in the room. So then the other thing is the family history. And that is always problematic in terms of figuring out what to do. But basically, there's like what, three other um, people with
Her
diabetes,
mother's
right?
aunt and grandfather. Yep.
So, we would, anytime there's a VUS, right, that's the way to go, right? So you let the genetics drive the whole thing, as you well know. So is it possible that the other family members could be sequenced? That's on the one hand. On the other hand, does any of this fit? Well, it's not like totally outrageous. I mean, age 21, boy, that could be anything. It could be type 1, it could be this. A1C, well, yeah, I've had people go into DKA with HNF1 alpha, um, and we don't have antibodies. the maternal aunt is interesting. So that's certainly possible. Um, and then, do we have even another generation? So I think it would be very interesting to see again. Now, I suspect you've already approached the family members.
Yes, but I did tell them about the uncertainties regard like I did not give them the specific MODA3 diagnosis. I did discuss with them that I'm uncertain about the diagnosis. I did refer to our genetics team as well. Their appointment is not for another month, but they are going. I did try to do. We have this new virtual consult, and the virtual consult I thought could help me out a little sooner, but they just recommended referral to their clinic. So they're going to go to the clinic, and I can now that they're scheduled communicate with that genetic physician before they see them, just to ask if the family could be sequenced or to let them know your thoughts as well because I haven't communicated with them beyond the quick try for a consult that I did
Yeah,
before.
so what we've done sometimes, although with a VUS it's harder, um, is to share some of the information with the mom, which you've already done, but to have the mom then share it with the mom's doc.
Mhm.
And that sometimes is helpful. I think most often it actually doesn't help at all. But sometimes it does. And if they're in the Hopkins system, maybe you have an adult endocrinologist seeing mom who like would get it. And I think if nothing else, even though her antibodies might be zero, if she's never had antibodies checked, now's a good time. It could still be zero. And then what do you do? So it is possible. We know now about one company, so I don't want to seem like I'm a shill for one genetic company, genetics testing company, and I think I just saw Dr. Poland join. But the one company I have in mind will not only repeat the genetic testing for the mom, and it's very inexpensive. So this may be the point to make to the mom's doctor if she lets you talk, is that, as you may know, that confirmation of a known genetic abnormality in a family member is a different level, and it could be anywhere from a couple $100 to maybe $400 or $500 maximum out of pocket, and not $5,000 or anything like that in order to confirm this variant. So, and I know Tony's going to say something in a second. So I think that could be helpful. And then the company that I'm thinking about also does a type 1 genetic risk score, which we're getting more and more excited about, and like it should be standard of care. So there, it's not yet available standard of care, but there are companies doing it. We're doing it on a research basis. TrialNet is doing it on a research basis. Um, and actually, yeah, so you already had antibodies. I was thinking that if mom had a diagnosis of type 1, you could actually have the child tested for antibodies and a risk score through TrialNet because she's a first degree relative. So what
Actually,
did
a
Tony?
good point. Yeah, I don't know if TrialNet would still potentially take her if we already have the antibodies tested, but potentially we
Right.
do have
So that's not
TrialNet at our
exactly.
institution, and I could speak with their some of the research coordinators who work for that. That's a
So
good
Tony
idea. Yeah.
points out that a couple of options. So LabCorp still charges $1,200. GeneDx is down to 100. And I was thinking of a company called GoPath, and GoPath I think has a charge in the several $100 range, but as I said, also can do the T1 risk score. So, this is one of those very interesting cases where it's possible true, and unrelated. So yes, she has a variant. Yes, she has diabetes, and we don't think the variant is actually the cause of the diabetes. We don't know what the cause of diabetes is, right? Doesn't mean she doesn't have it. But with the other situations, which may actually be very interesting. So almost everything you could say, okay, lung disease, optic atrophy, small for gestational age, developmental age, all of that could be prematurity. I totally see that. Um, but Tony points out that there is still a knock on GoPath, but they report the data, and then we could help review the risk score, which they do report. So Tony, I don't know if you saw the. Let's go back 2 slides, and because a few people joined, I just wanted to be sure um, we have a few more minutes in case anyone else wants to. So the bottom line here is that we have a variant that's a VOS. It's a 6 I believe, did I say that? A six amino acid, eight amino acid deletion from 460 to 468 in 1 alpha, which is in the uh, transactivation domain. But the problem is that the frequency is a little bit higher, in fact, a couple of orders of magnitude higher than we would have liked to see, and doesn't explain the high C-peptide insulin resistance feature of this individual. So with that, that's the summary. So again, we're not. I'm hard pressed to blame her diabetes on this variant. So I don't know if we have a few other people who might want to help me out here. So I don't know, Tony, do you know about this variant?
I'm trying to refresh myself. So Lisa looked like you said, do you know what the frequency was? I'm trying to
Yeah,
look it up,
so
but
I do have the frequency. So again, this is in HNF1 alpha. It's 1380 to 1406 on the DNA side, and it has been reported. So it's um, let's see, it was in BMC Medicine in 2019, and it was from a French group, although I don't see. Oh yeah, and Cecile was on the paper. So Cecile
Mhm.
Saint-Martin in Paris was part of this paper that mentioned several different variants. So the idea of the frequency is that it was reported at. It says, and I'll just read it to you. Uh, in high allele count of 87 hets in the admixed American group, which included the gene filtering allele frequency of 0.00096, whereas in MDEP you've been using, Tony, 0.0000033. So it's really much higher than we would have expected.
Right. And actually, that's even not only above the PM2 supporting, but that would be a frequency that would we call like automatically benign because it meets BA1. So it's like the standalone benign criterion. Of course, it may be a risk variant. So if it may be common enough, if there's enough of that population, like in MT2D, you might be able to see if there's an association. So there's always the possibility, but it's too high to be, unless of course, like we didn't realize that in that population, there's like a ton of people with, you know, with MODY, but it's generally in our rules, it's too high to be a monogenic diabetes variant without even any other. Uh,
Right. So we hesitate to rule that out on statistical
yeah.
frequency alone, but it could be in this case the most important criteria. With that and the fact that her C-peptide is high and not low. But I think all of these things are incredibly helpful to review in sometimes excruciating detail
Oh wait,
to,
I see it now that it's in our
yeah.
it's in yeah, it's we have it as in progress and we had it as now that's interesting. We had it as PM2. Yeah, this is the same one. We had it as PM2 supporting, but maybe that was probably with maybe the old version. Because yeah, now I do see that it says yeah, there's actually even a homozygote in the admixed American
Yikes. And the
population.
homozygote had diabetes or didn't have diabetes?
Well, what I'm looking at now is just
Yep.
Nomad, so we
Yeah.
don't
So
we
we
don't
can't tell
know.
details.
But just, there's 70, yeah, let's see. There's 71 in the admixed Americans and let's see, I'm trying to see how to OC data in Nomad 4. Okay, yeah. Yeah, so this is yeah, so that's where you got the yeah. So now I'm wondering we had applied PM2 supporting, so maybe before, let's see if we lift over to 2.1. Yeah, I'm not sure why we call that PM2 supporting because
Yeah,
it's
so
still,
it's getting less and less likely that it's significant, but it's important. I think all of these things
yeah.
to take in mind to understand for the people who are listening that that we have to go through these things very carefully and make sure there isn't some other aspect to it. Obviously, there's liver things that happen that may not be diabetes. We're not yet sure how the various dots are connected. We have people with liver tumors and HNF1 alpha mutations. And so it might not be, is it possible one of these things separates those things from diabetes, the other? We don't know. But Tony, before we go and leave this case, I wanted, so if go now back to the next slide, one more slide, Ava. So this is the additional medical history, Tony, if you can see the screen. So just to be,
Okay.
all of this is potentially or most likely consistent with prematurity, which was the problem with this child. And
Mhm.
but there's, I didn't want to exclude the possibility of some other chromosomal variant, and I don't know if anything would jump out at you here.
Chronic lung disease, SG, developmental.
So sadly, these are all things that happen, from prematurity.
Yeah, I mean, yeah, and they're kind of not like otherwise like kind of non-specific. Like, I mean, I guess, yeah, like the so it's not like there's some disorder jumping out at me. I'm like, oh, optic atrophy, like,
And so it does, so we're still left with the question. I mean, her blood sugars are not completely normal, um, and her C-peptide is high, so there's some element of insulin resistance, and it's not obvious, why that should be. Although it's, but at the moment she's not being treated for her diabetes.
No, I've just been monitoring her. So she's been on the Dexcom intermittently. I've been following the A1Cs every 3 months.
I'm having trouble hearing you.
Oh, I'm so sorry. Can you hear me now?
Yes,
Okay.
or not actually. For a second I did, and now I don't again.
So there's some interesting, there is a hint that it could be contributing to the diabetes. So I looked it up in the type 2 diabetes knowledge portal, and it says HbA1c adjusted, oh wait, HbA1c adjusted for BMI, beta of 0.46 and with a p-value of 0.02, and then type 2 diabetes, an odds ratio of 2.7 with a p-value of 0.07. But it's probably it's hard to tell how many there are, but it's going to be quite small. Um, in rare in this is in Yosep's rare variant type 2 diabetes meta-analysis in a sample of 180,000 people, and then also in all of us, which I think are independent.
So let me
Although
show
actually, no,
sure
I
I
think maybe they're
understand.
not. They're too similar. I think they're the same. I don't know. I
So you're
think, yeah.
saying there's a small contribution maybe to type 2 diabetes.
Yeah, there's a non-significant but close to p of 0.07 for an odds ratio of 2.7 for increasing risk of type 2 diabetes. So this could be contributing in some way.
But I would argue that, the risk is actually when you lower insulin secretion and not here. So this could actually say that there's something confusing about this in the absence of other risk factors. But all right, so as I
Yeah.
say, I still think it's interesting to, although complicated in terms of sort of the actual human interaction, to see what additional testing mom could have. Um, my experience has been that when you suggest that, people get get excited that you're onto something, and it really is a technical point. Um, but I think it's extremely interesting, and we're really pleased you brought it to us.
Yeah, and yeah, there's
Thank you
always
so much.
yeah, that's and like you can think of why some people would really latch onto this, but we don't really think it's, the cause. And so, yeah.
I think
Yeah, no, this is very helpful.
as we've gone along, we just found that we have to be extremely careful in being sure what we say, that people don't sort of, oh, well, I don't need insulin anymore or something like that.
Yeah.
So there it is. Okay, so great. So hopefully you'll send us more cases now that you know that these things happen, and they're way less rare than I think we thought for a while. So that's great. So thank you again. I don't Any other comments, or I see you put the chat there, so that's great. Okay, well, great. So thank you, and let's stay in touch. And if anything changes in this family, we certainly want to hear about it as well. Okay. So the next case is one of ours, I think,
Yeah.
Ava and Michael.
Yeah, I think, yeah, there we go. So I can talk about this one. So Hi, everyone. My name is Michael. I'm a research coordinator with our uchicago monogenic diabetes registry team, and happy to discuss this case. Like Dr. Phillipson said, this was a participant in our registry who is from a family with HNF1 alpha and was a new family member who presented with new onset diabetes, and the family came back to our group to discuss genetic testing and um, other ways to figure out what was going on. And we thought it played out pretty interestingly and would be worth discussing with the group here today. So, um, yes, perfect. So, like I said, the individual who presented with new onset diabetes was 13 years old. At that time, he had no other significant medical history. He had symptoms of fatigue, 20-pound weight loss, polyuria, polydipsia, and on a home glucose monitor, they noticed that the blood sugar was elevated. When they came in for evaluation in a clinical setting, they reported blood glucose to be 480 mg per deciliter. HbA1c was 14%. There was no DKA, and his BMI was 11th percentile for his age, though um, prior to the 20-pound weight loss, BMI was approximately 80th percentile. As I mentioned, there is a significant family history for HNF1 alpha MODY. This individual's mother, a maternal uncle, two maternal aunts, a maternal first cousin, and the maternal grandmother all have pathogenic HNF1 alpha variants that cause MODY. And also on the paternal side, his father has lupus, and his father's mother, so the paternal grandmother, has multiple sclerosis. And on the next slide, we put a pedigree together just to show that um, visually here. You can see the bottom left, generation 3-1 with the green square is the 13-year-old with new onset diabetes. You can see the maternal side with quite a bit of HNF1 alpha MODY represented in the red. And then the dad with lupus and the paternal grandmother with multiple sclerosis. Another thing worth mentioning here is we show the different ages of diagnosis for the individuals with HNF1 alpha MODY, and you can see that even within this family with the same HNF1 alpha variant, there's quite a bit of variability ranging from 10 years old all the way up to 48 years old, even in the mother, which is a little later than we usually think of for being diagnosed with MODY. So that's the family history, and given all of that in the clinical presentation, a thorough workup was pursued, and here is the result of that. The diabetes autoantibodies, IA2, GAD65, and zinc T8 were all positive. Our research team did single gene Sanger sequencing on the HNF1 alpha family variant, and it was negative for the 1 alpha variant. There's the specific variant in the sub-bullet. And we also did a T1D genetic risk score, which revealed a risk in the 25th to 50th percentile. So given all of that, a diagnosis of type 1 diabetes was made. He was started on insulin therapy. And when we last talked to him, he was on a multiple daily injection regimen with a total daily dose of 32 units, which was about 0.71 units per kilogram per day. And then 3 months after diagnosis, an A1C was much improved at 6%. And then I think we can go to the next slide. So just some interesting discussion points or takeaways that we had from this was that many different forms of diabetes can all have similar phenotypic characteristics. And even if there's an individual with a family within a family who has HNF1 alpha MODY or any form of MODY, you shouldn't just make an assumption about the cause of the diabetes. When indicated, it's important to perform genetic testing. Like I said, the age of diagnosis of HNF1 alpha MODY can be highly variable and can occur even beyond that usual cutoff that we think of 35 years. And we do like to highlight also the potential utility of the T1D GRS and giving some insight into the underlying etiology, especially in the context of other autoimmune conditions. Um, and yeah, I mean, I think that was all I had, Lou, if you wanted to.
Well, there's actually, any of these cases, there's a lot that could be said about it. I could make a few comments, but Tony, you saw it was kind of sobering to see this. Do you want to actually say a few things first?
I
Yeah,
think you
we
may
got
be
you muted.
muted.
Oh, yeah. There we go.
Yeah, no, I mean, I just, yeah, I mean, I saw this and I was like, oh, they didn't, I mean, once I saw the result, I was like, well, maybe they did test him at some point, even though you're not really supposed to test people, that young. And, but yeah, no, it's sobering. Yeah, that was one thought, because like, yeah, I thought he was going to end up having the variants that he's got this really high antibody titers, clearly type 1. He's got and with the family history of the MS and the lupus, like that makes sense. I was thinking like this is probably like not like a case more for like if you were teaching, like it would be more for like an advanced lecture, because I think this is the kind of thing that people would see if they didn't know a lot and be like, oh, see, so so this genetic stuff is, but yeah, I mean, this is really, really important and instructive. So I think it's a great case. You should I would definitely hold on to it and use it for all kinds of teaching. So.
Yeah, one of the things I wanted to go back to the family history with the ages because I think maybe other people could comment. So you made a point, Michael, of since the cases we think it's solved, but it is striking. I mean, we often see mutations in one alpha where people are about the same. I have one pedigree that I'll never forget where like everybody gets diabetes at age 19 and that's also an HNF1 alpha family. And so here we have this pretty amazing disparity between anywhere from what the youngest person was 10 and the oldest at 48 with exactly, and the mutation is not subtle. I mean, this is just to spend a few minutes talking about the nomenclature. Let's actually do that. So go back to the gene since we have an expert with us. So the gene itself, ought to be straightforward. Let's see where the mutation is. There we go. So, I mean, this is a truncation. So I don't know how much of it is nonsense. Maybe I don't know if Tony, if this one is familiar to you, but so this is a C to T variant at 370, and it looks like there's a stop at 124. So this would be decay, loss of the transcript, and so it's basically haploinsufficiency from the get-go. Is that fair to say, Tony?
Yeah, sorry, I realized I was muted. Yeah, I mean, I don't even have to look because this is a 10 exon gene, and this is like, so I don't know which exon it is, but it's not in the last exon. It's not, it's toward the beginning. So yeah, so the expectation is that this is a null variant, and so
And so what's extraordinary is that with the range of variation. So so we've tried to start this idea as asking the question, what could be the basis for that level of variation? And that's important for families to know that, people still need to be tested. And just because you hit 35, you may not be in the clear as far as getting diabetes. So, there's the obvious things, exercise, the degree of obesity, and obesity is huge. I don't know that we know the BMIs of the individual family members here. It's interesting that I'm
I
thinking
was
about that.
thinking also ascertainment. Like, I mean, it seems like it's weird if I don't know what the actual ages of those people are, but it's weird that, it'd be weird that she wouldn't know until she was 48 and she was actually, when was her onset? Was how early was it? And, just are people more,
Well,
you
that's
know,
right. So, so then they ask more questions like, did you, how is it she wasn't having diabetes when she was pregnant? How did she escape that?
Mhm.
So it does raise lots of interesting questions about the pedigree. You can show the pedigree one more time, Ava, too. So as I say, there's these family histories are very rich in terms of what you want to think about. So there's mom was probably diagnosed the generation one. She was diagnosed at 16, so she knew going into her pregnancies probably that she had some kind of diabetes. The other ones are more variable. I mean, number five, we don't know if they have had children or not offhand from this pedigree. Um, Number two was diagnosed at 48. That seems odd if she had two children and somehow didn't get diagnosed. Is that right? I
But
mean,
I wonder if that detail is just like I'd be interested in seeing that detail. Like maybe she had GDM, but she didn't reach full-blown diabetes until she was 48. Maybe her pregnancies were late in life to begin with. So yeah, so I'd want to know sort of more about that. Also, what kind of diabetes, grandma maybe had type 1, had a diagnosis, what was her, like, she was diagnosed with diabetes at 16, but when was she diagnosed with MODY? Probably not at 16.
that's right. So there could be a difference here in terms of when diabetes was diagnosed as to when the genetic diagnosis was made. So that also could account for the ages. Would you know? So it says diabetes diagnosis age though, Michael. So I imagine
Yeah,
I
from
think
what
about
I understand, that's when they were diagnosed with high blood sugar.
yeah. So that's very interesting. And some so what it suggests is, I mean, if assuming that's all true, then there may be some genes here that or so lifestyle, environment, obesity, that can play a role in delaying diagnosis. There could be genes that are protective, which actually have never been described as far as I know. And there may be genes that could be accelerating, which also is interesting. So I know several groups, including ours, we took a shot at doing uh, type 2 diabetes risk scores, which probably too early for prime time. But in a family like this could be interesting. Is there more of some of the uh, GWAS studies that showed type 2 diabetes risk, does that play a role here? So we don't know the answer to that
And it's
question.
certainly, I mean, that's certainly something that just has shown, that the type, yeah, that there's an interaction. Yeah, it could be lots of things. And yeah, certainly the genetic background would be interesting to look at. I mean, and I know there has been work done in that area, even kind of pre-genome era, like in diseases like cystic fibrosis and Marfan syndrome, and they've been able to. I know with Marfan syndrome, there was one family where they found like the gene that made people not have an aortic dissection if they had, even though they had Marfan. So, it could be digenic. There could be some specific thing to find, or it could be just that the background is quantitatively different.
So all of which illustrates that there's always another question to be asked. So I think it's very rich to have a family like this and to see the variation. So that could be something we could follow up on too, Michael, even though the main point is that, we have the possibility of a child of somebody with HNF1 alpha who also has type 1. And we've seen other things that are also as you say, sobering. One is we had one family member a long time ago where one sibling had GCK MODY2, another sibling from the same parents had type 1. And that's been described, I think, also in the literature. So it's good to be sure what you're talking about before you make judgments and change therapies and things.
Our,
Still,
our KCNJ11 family, she reported a second cousin with type 1 diabetes, but the mother was de novo for the variant. Like, she had a second cousin with type 1 diabetes. Not that surprising,
have
but,
one, I
kind of
know
disappointing
one
for him.
Yeah, I have one HNF1 alpha one KCNJ11 with celiac, which, is, so again, there's no association there. It's just bad luck. So those things happen. So this is great. Any other comments from the group before we end today's session? But I want to thank everyone for listening. We had quite a few people there on, and we'll continue to do this from time to time. And Ava, if you have a few words to wrap up.
Yeah, I just wanted to say thank you to everyone for coming today. And thank you, Dr. Poland and Dr. Hitt for presenting, and thank you, Dr. Phillipson, for all of your insight.
Yeah, so thank everyone and keep your eyes open. We'll definitely be letting folks know when we do this again, which we try to do once a month-ish, and that's where we're at. Okay, have a
Can
great
I
rest.
just also, I don't know, I've been in communication. Oh, just one thing. The link that was sent out both today and in a previous email was different from this link. So I don't know if there were other people trying to join
Oh,
and gave
okay,
up.
so we'll try to
Uh,
be sure we get that right next time. Sorry.
yeah,
Okay,
yeah. Just
okay,
to
all
let.
right.
Yeah,
Take
thank you.
care, everyone.
Thank you.